Hello, dear colleagues. It's a pleasure for me to share with you this presentation on behalf of WHO. Also, I would like to thank the organizers for the opportunity to share my insights on the triple elimination of HIV, syphilis, and hepatitis B, married to child transmission in the context of funding restrictions. I'm Dr. Casimir Manzengo from WHO Burkina Faso. I'm in charge of HIV/TB hepatitis program covering Benin, Burkina Faso, Niger, and Togo. I'm passionate on triple elimination for three reasons. First one, I was championed for mother and child health in my health district when I was a young doctor. And after this, at the beginning of the Global Fund in 2022, I was championed for PMTCT implementation in the rural area in DRC. And third one, when the discussions started to transition from double elimination to triple elimination, I was the hepatitis focal point at the regional office, and I was the first to start the training of Afro countries on the PMTCT of hepatitis B. So some colleagues are saying that I'm a triple champion for triple elimination. So it is my pleasure today to discuss with you and share my insights on what can be done in this financial situation we are now facing too. During my presentation, I will try to respond on the question that in this current context of funding restriction, should we still rely on the triple elimination or should we give up? This is my main question. I will try to respond during our meeting, and I will be open to discuss more further on this at the end of my presentation. To do this, here you have the outline of my presentation. I will start by an overview of the triple elimination, and I will present the current situation of funding in the world now. And I will discuss with you why should we maintain the efforts of triple elimination and how we can do this. And I will close by a summary, like a take-home message. What is the rationale of triple elimination of MTCT for HIV, syphilis, and hepatitis? Those three diseases are transmitted sexually and vertically from mother to infant. They can also cause significant maternal and child morbidity and mortality. They are often silent with long latency periods, and affected mothers may be unaware and have no symptoms. They can be identified during the antenatal care service and treated to prevent vertical transmission from mother to child. This slide is presenting the epidemiological situation of HIV, on the left side, and syphilis on the left side at the bottom, and on the right side you have the viral hepatitis situation. Globally, when we saw the improvement of PMTCT coverage, the situation is very different in some countries. Like here you can see that in West and Central Africa countries, only half of HIV positive pregnant women are on treatments for to prevent the transmission of HIV to the children. So when we see the second one for hepatitis syphilis, we can see that the Africa region have the high rate of congenital syphilis. So it is a situation should be addressed. And when we consider the regions, sub-regions in Africa, we can see that in the West and Central Africa, the situation is bad for syphilis. And considering hepatitis, you can see in on the right side that most of the Afro countries have a prevalence above 1%, and the situation should be addressed by triple elimination. This slide is showing the framework from the implementation of triple elimination of mother to child transmission for HIV, syphilis, and hepatitis B. We have 4 pillars. The first one is the primary prevention of vertical transmission. The second one is sexual and reproductive health leakages and integration. The third one is the essential maternal MTCT services, and the last one is infant, child, and partner services. Those should be integrated to make sure that we are going through the triple elimination. Coming to the funding situation, many events happened since the inauguration of the US elected president, starting by the withdrawing from WHO, the freeze of USAID and PEPFAR support to the HIV program, and all of these situations are making the financial situation very bad for HIV program and the PMTCT in particular. And we can say that should we maintain our effort for triple elimination, or should we give up? This is the question we are trying to respond during this presentation. This slide is showing us the service disruptions assessment done by WHO this year since the freeze of financial support from US. You can see that many countries are experiencing the service disruption, going from 5% to more than 50%. This is not fair. So something should be done. This slide is showing the impact on the person living with HIV who are now losing the access to ARV treatment. Many people, including children, are now facing some difficulties for the ARV treatment. The most affected countries are South Africa, Mozambique, Kenya, Tanzania, Uganda, Nigeria, and Zimbabwe. And the tendency is to panic, but I can say that don't panic at this stage. We should be organized. We should organize our program and to see how to go forward. Although this challenging situation, we should maintain our efforts for triple elimination. One, for the health benefits, as you see previously, the PMTCT can help us to reduce the transmission rate of HIV, syphilis, and hepatitis, and also to improve the health outcome for mothers and children. But secondly, it is also to contribute to the global health goals. First one, to be aligned on the WHO recommendation, but also to contribute to the SDGs for 2030. How can we maintain our efforts when funding are cut? I'm going to share with you 3 key points. And the first one is the prioritization. We should have the data-driven program to do the right things on the right place at the right time. Clearly, it is not matter to do all things everywhere at all times. We should identify through the data use and data analysis where the problem is and what can be done there and when. This helps us to reduce costs for our program. Second point is integration. I'm going to press here the one-stop shop delivery. We should organize our PMTCT provided by the same healthcare at the same place and at the same time. It is the one-stop shop delivery. It is normal to have the standalone PMTCT program. It does not work. We should see how to integrate all the package of PMTCT at the same place. It is cost effective to provide PMTCT at the same place by the same provider on the same time. The third key point is innovation, not business as usual. 3 sub-points. First one, the soft collaboration. It means the possibility for countries to have help by the peers, like when a province or health district or health facility is performing well, it can use to help other province, health district or health facilities who have challenging some problems. This is cost effective. Second sub-point is simplification. As in the past for HIV we use the test and treat, we should do the same for hepatitis. It is now recommended by WHO where the DNA and other tests are not available, we can go straight to the TDF prophylaxis when pregnant woman is tested hepatitis B antigen positive, surface antigen positive. The last sub-point is digital health for monitoring. We have now many technologies available to help us for data analysis, data use. They have artificial intelligence. We can use all of these possibilities to improve our quality of monitoring. In this slide, I would like to share with you a case study on BBNT initiative. It is a SAF-to-SAF collaboration based on data use and sharing experience to strengthen HIV, TB, and malaria program between Benin, Burkina Faso, Niger, and Togo. We started this initiative in 2023. At the end of 2023, and last year was the first implementation year. You can see here the 4 countries covered by this initiative: Benin, Niger, Burkina Faso, and Togo. And it is for HIV, TB, and malaria program. But coming to PMTCT, our analysis showed that the coverage for PMTCT was different between these countries. And in Benin, it was 94% in 2023. In Burkina Faso, it was 84%. In Niger, it was 32%. And in Togo, 79%. You can see the difference between these countries. So I discussed with these these countries to see what can be done. Should we go outside to check, to look for the technical assistance, or we can use the expertise you have? Because I can see that Benin has 94%. You have the secret to share with other countries. What was my first discussions I have with countries, and we put in place, we set up the BBNT initiative. BBNT represents the first letter of this country: B, Benin; B, Burkina Faso; N, Niger; and T, Togo. And the strategies were the webinars and peer country support, visit, and sharing experience workshop. Those were our strategies to implement the BBNT initiative. In this slides, I'm going to share you some best practices in PMTCT shared between these 4 countries. The picture here was taken at the Amazon in Benin. You know this place, I think. When the Togo team went to visit the Benin, went to Benin to share the malaria, tuberculosis, and HIV best practices. So, coming to PMTCT, we can raise here some best practices shared. First one was the weekly follow-up of prioritized PMTCT sites in Togo. Secondly, we have the audit of the PCR positive exposed infants in Benin and Togo. We have also the integration of private sector health facilities in Benin. We have also the use of GeneXpert machines for PCR and tuberculosis. We have also the prophylaxis all implementation in Burkina Faso. And lastly, they have shared also the community involvement in the 4 countries. They have the good experiences. So those practices were shared, and other countries took them for implementation and to improve the quality of PMTCT program. To summarize, I'm going to respond to my introductory questions. Should we rely on triple elimination? Yes, of course, yes. How to do this? 3 key points. The first one, prioritization, to have the data-driven program. Integration, one-stop shop delivery, and innovation, ways to do things differently. I think that doing this, we can help our program, PMTC program, to be maintained and continue to work for triple elimination, which is our goal. Just to end by thank you all of you and share with you some references and documents used to prepare this presentation. I'm now open for your question. Thank you for your attention.